I'll start off this talk with a story. When I was in medical school, more than maybe, let me not say how long ago it was. One of the senior clinicians then said this, and it resonated with me. And when we studied this study, it came back to my memory. ICUs where patients go to die, and perhaps he had a point, but um, when we decided to start this study, we thought that we would actually find something, well, maybe different. But we tend to think of mechanical ventilation as an intervention, yet it's not just an intervention, it's a system of care that is more like cogwheels put together. And you need sedation, you need protocols, you need staffing, you need to wean the patient off as soon as possible, you need to deliver it appropriately. And so when we think about it just as a machine and just setting the ventilator and then walking away, you forget the fundamental aspects that come along with this care that you're going to deliver to a patient. And so it's important that when you put a patient in a mechanical ventilator, know that you've introduced a myriad of interventions that are going to be, that need to be applied to allow survival. So there have been so many studies from high-income settings. And when I decided to look through so many of these studies, they all have a similar image. Somehow, Africa is missing. Somehow. Is it that there is no data, or that the data that exists is not being included into these studies? But they all look like this. The distribution tended to not so much include sub-Saharan Africa. And this study done by our own keynote speaker here looked at an amalgamation, basically putting all these global studies together from different regions and looking at the geoeconomic variations and outcomes related to that, depending on which country you're being ventilated in, how likely you are to survive. And as you can see, the blue, the graph here shows survival, and the blue is high-income countries, so the survival is high in the high-income country. So then why don't we just copy and paste what the high-income countries are doing, and we just do it here, and we see the same outcome. There have been a couple of studies that have been done, copy and paste into Uganda, FIST trial, and then one done in Zambia looking at mortality in sepsis, and the outcomes are actually much worse than what we expected. The mortality in the intervention groups was higher than you doing what you've been doing every day, okay? So you can't exactly just copy and paste from high-income countries. From that very study, what Luigi and team found was that if you do not have ARDS is the condition where the chances of mortality is extremely high, whether you're in a high-income country or low-income country. So if you look at participants who did not have ARDS, but they were ventilated in a low-income country or low-middle-income country, or middle-income country versus high-income, the chances of mortality is 16% higher in a middle-income country. And the question is, why does that happen? We certainly cannot change the gross domestic product of Uganda. The president has said we are now a middle-income country. Does that mean that if you go into an ICU, the chances of death is less? Maybe not. I think the most important thing is to do the really simple things really well. And the question to ask yourselves when you go back to units is, are we delivering mechanical ventilation, or are we delivering care for the mechanically ventilated patient? And that should be the key question you should need to ask. And so in the MOTIVATE study, we asked ourselves, what can we actually change? We can't change the patients who are showing up to our ICUs. Dr. Adam talked about the SEOs. The patient doesn't, 41% of the patients don't get, or only 41% get oxygen. And then the ward realizes, oh my God, this patient is dying. And then they rush to the ICU with a patient who has not been receiving oxygen, and they're expecting a miracle, okay? And truth be told, you guys work in the ICU, you perform miracles. A majority of these patients should not be alive today the ones who have made it out. Because in an era where there's no ICU, they are dead. Okay? So we can't really change the illness severity. Perhaps with the SEOs and the data that we have, we can start to handle the issues backwards. But there are those who still trickle through and will end up in the ICU with the organizational factors that we have to think about. The ICU staffing models, and that has already been highlighted here. One ICU says, oh, I have all the nurses I need in the world. And the ICU saying, you know my challenges. I don't talk about them. Okay. And then of course intensivist coverage. One ICU saying I have 24/7 intensivist coverage, another like I won't comment about it. So in all this, the organizational structure really sets up a foundation to implement protocols, to change the way we sedate the patients, to change how soon we are going to try and wean the patient off by performing SBTs, SATs, and doing protective ventilation. So we did the MOTIVATE-ICU study. At the time, we had 19 ICUs that were, at the time, were the ICUs in Uganda that were ventilating patients between August 2024 and March 2025. And we had about 625 patients who were ventilated. I don't have it on my slide there, but I'll tell you about some of the outcomes of those who were ventilated under 2 calendar days. And then, of course, this was a study that was embedded within the registry, and you all took part in it, as I've had a couple of you mention. And one of the things I was talking to Albalo earlier this morning is the findings in this study were actually a lot related to what nurses do at the bedside. So it echoes the idea that the care we are delivering is the one that really matters, not the mechanical ventilation that we're delivering. So these were some of the sites. Functional sites are in green, and as you can see, a majority of them are within Kampala metropolitan. It hasn't significantly changed, but if the government can enhance the regional referral ICUs as per the regional plan of 10-bed ICUs across the country, then this is going to allow a more distributive access to intensive care for other patients who may need it. Otherwise, referring all your patients to Mulago and then expecting Mulago to perform miracles is unfair to the Mulago team. So, who were these patients? The median age of our patients was 47. When you compare this with the previous epidemiology study that was presented by Alice, this population is older. They're a decade older than the entire population. So age contributes to the likelihood of ventilation, of course. And again, like someone said earlier, males don't like coming in for healthcare, so they come in pretty late and then they end up consuming all our resources. So males, please improve your behavior. And then, of course, comorbidities. Previous studies actually showed comorbidities much lower because these were largely single center studies, most in the public ICUs. But the moment you include private hospitals and PNFPs, then you see a lot more comorbidities contributing to ICU admissions or being prevalent in ICU admissions. And hypertension was the most prevalent. So when we go to the outcomes, at this point I thought maybe I should give you a quiz and you select which potential mortality you expect that we had. But we had a quite high mortality, nearly 50% of our patients. That means 1 in 2 of your ventilated patients is going to die. Okay? Just think about that for a moment. 1 in 2 is not leaving the intensive care unit. This is the entire country. Okay? And then median ICU length of stay, that's for those who actually are going to stay in the ICU, they will stay for a long time. That means they're going to lock up the bed. You can't admit another patient. And then when you look at ventilator-free days combines mortality as well as the time you spend free of mechanical ventilation. So it's more of a composite outcome. And 1 day. What that means is that patients had only 1 day. The ones who were ventilated only had 1 day free of ventilation if they had not died. And that is quite daunting when you think about it. So in other words, we didn't have a lot of people getting out of the ICU, and those who got out of the ICU spent a lot of time receiving mechanical ventilation. And when you looked at the secondary data, in other words, hospital outcomes, only 3 of our patients got out of the hospital, of those who were ventilated. When I saw these results, I couldn't believe it. I had to vent a little bit. I think I came to Adam and Fred, and I told them, "You guys can't believe what's happening." I didn't think it was this bad, but when you think about it in light of the context, previous studies, Quizera et al. 2008, and Dr. Jen is here. They did this study. It was largely a single center study. Mulago mortality in the ICU. This is not just ventilated patients, but to be fair, Mulago at the time would not admit you if you're not getting ventilated. So to be fair, 40% is largely ventilated patients. Mulago patients, if you need oxygen, but you don't need a mechanical ventilator, you don't need ICU, okay? That's how it tends to work. If you don't need mechanical ventilator, you're not getting in. While some other high-end ICUs, if you need a bit of oxygen, 5 liters, come to ICU, you shall take care, okay? Mulago doesn't have that luxury. Yeah, so then Dr. Tendo and team in Mbarara, that's the western region of Uganda. Again, Mbarara does not have the luxury of taking you in if you don't need mechanical ventilation, so close to Mulago. And then, of course, Irene Chamumi did a study looking at mechanical ventilation in, I think there were 4 ICUs, and again, finds it about 40%. And then the study done by Atumani et al., when you looked at just mechanically ventilated patients, the mortality was actually higher. It went up to about 50 to 60%. But the broader study found 25.6%. And in this study, it sort of fits the narrative that our mortality is pretty high. 50% is a very high mortality. So what can be changed? And this is what the study was aiming out to find. So what we found is sedation depth was quite high in those who didn't survive. So in other words, for every day that you spend with moderate to deep sedation, the chances that you would die would significantly go up. And we try to control the confounders for this. But of course, being an observational study, you can't control for all confounders. And this would be difficult to do even if you tried a clinical trial. There's some other variables that will come in. But lighter sedation has been shown to actually improve the chances that we take you off the ventilator and get you out of the ICU. The other one was performing spontaneous breathing trials. In other words, when the patient is eligible to breathe spontaneously, give them that opportunity to do so, because the longer you keep them ventilated, the chances of taking them off is higher. So those who had higher SBT performance seem to perform or to have a lower mortality and more ventilator-free days. And then the staffing, and this was one of the organizational characteristics that we found was quite significantly associated with mortality and ventilator-free days and median length of stay. 1-to-1 nursing, perfect. 1-to-2, good. The moment you are beyond 1-to-2 and your ICU nursing staffing is 1-to-2.5 and above, or 1-to-3, the mortality was exponential. It kept going up. So when we did 1-to-3, 1-to-4, it just kept going up. So the odds of mortality just kept increasing. And then what we found also is that intensivist presence increased the ventilator-free days, which is actually good, because intensivists will potentially allow you to make an appropriate plan, and the nurses being available will allow that plan to be implemented. So these were some of the findings that we had. So this evidence belongs to all of us, not just the ICU sites that were part of the ICRU, because this is generalizable. So whatever site is coming on board, know that this is going to be very much applicable to you. And so the question here, rather the issue here is the study was powered by the registry data that we all generated here. And of course, it's nationally representative because these were all the ICUs that were part of the registry. And so what you go with here is check your sedation practice in your units, and see those patients who are deeply sedated, do they really need it? Very few patients in the ICU really need to be deeply sedated. And some ICUs have adapted to either the lack of sedatives or the abundance of sedatives. The ones who have abundance of sedatives tend to be the private ICUs. They have a lot of sedatives, so they sedate for quite a long time. Then public ICUs don't have that much sedatives, so they don't sedate so much, okay? And then, of course, there are risks on both sides, as seen in an Ethiopian study. When you don't have enough sedatives or you don't do an appropriate sedation, there's accidental extubations and mortality. If you sedate them too much, then you have increased ventilation time and increased mortality because of the complications that come along with that. So there is a sweet spot that you have to think about when you have abundance or you don't have an abundance of sedatives. Then do you do spontaneous breathing trials every day? Do you try to let these patients breathe? Okay, every day you ask yourself, should we let this patient breathe today? Because if you don't, the diaphragm starts to thin out, they start to struggle to get off the ventilator. They're likely, every day they spend on the ventilator, they're likely to get ventilator-associated pneumonia, and then it becomes a cascade, and then more nursing power is needed, so it becomes really difficult to sustain that for 10 days for 50% of the population. So the QI agenda, the quality improvement agenda here should really be, as we set out initially, was to be locally driven data. And this is the data that you can now take to your administrator and tell them, look, this is what we have found. 1-to-1 nursing, 1-to-2 nursing is the appropriate nursing ratio for ventilated patients. We need you to do better by these patients. This data is going to be published, and of course the population is going to know, and they probably will start asking, do you have 1-to-1 nursing here? Do you have 1-to-2 nursing here? Okay, so that is coming. So ICUs where patients go to die, 1 in 2 still die. So perhaps there is a certain element of truth to it, but it's not completely true. Only 50% of our patients make it out. But we know that some of those deaths are really associated with things that we can really change, and we should try to change that. So thank you for listening to me. Acknowledgement stories.